How do we feel about where the pillow is relative to RJ's shoulder right now?
Not from where I was. I want either him to scoot down more.
Yep, so we'll either have him scoot down more or we'll have him lift up his head, and we're gonna make sure that that pillow is not behind his shoulder. We want that shoulder blade to be able to come down to the table all the way. And just in looking at RJ's shoulders, you guys can come stand on either side. And this is gonna be true for pretty much everybody you meet, but it's just good knowledge to have. We can already just start to look at his posture. If there's any space between the table and the back of his shoulder, that tells us he's laying down in a slightly protracted position of the shoulder, which means maybe he's got some tightness going on somewhere that could be affecting his ability to get his arm up and down. So I'm thinking, all right, what are the muscles that protract? Maybe pec minor could be a little bit tight. Maybe serratus anterior is a little tight. Who knows? Like we've got some investigating to do. But even just here, before I've even done anything, I'm already starting to get a picture of like what RJ is capable of, just how he's laying, and making sure that you have plenty of space to be able to make that assessment. Because if the pillow is wedged up under him, then that's going to throw off what we're able to glean from him already. Okay, so let's do the 4 range of motion measurements in supine. That's flexion, abduction, and internal and external rotation. So again, our goal here, especially if our patient has a lot of acuity or has recently had surgery and they are apprehensive about moving, we've got to cradle this arm like it's a baby. We got to make sure the patient is fully supported so they can relax. Then we can deal with the goniometer. But just as a reminder, for flexion, we're going to use the greater tubercle for our fulcrum. So again, if you find the lateral aspect of the acromion, come just a little bit down, you're going to feel that rough surface of that bone. So that's where our fulcrum's going to go. Our stationary arm is just going to follow the torso, just a nice straight line down. And then the moving arm, RJ, let me see your arm. If we follow the arm all the way up the shaft of the humerus, we can see now that the olecranon is kind of pointed at us. So we're going to go ahead and use either that, or if we, there we go, or the, actually, what did I say in my notes? So that's consistent. Lateral epicondyle. So if the acromion is facing you, there might be a little bit of rotation there. So let's go ahead and stay consistent with the book and use the epicondyle of the humerus there. And that's the position we're going to get to and how we're going to set up the goniometer. But let's say RJ has a lot of pain. The first thing that we're going to want to do, since I could already know that I got his arm up there and it was hitting the pillow, we know the pillow's in the way right now. So step 1, RJ, lift up your head. We're going to slide the pillow over and then relax. So he still has support under his head, but now I've got plenty of room here to be able to assess his range of motion. So now I'm going to tell him what I'm going to do. So RJ, I want you to relax your arm as much as you possibly can. I'm going to hold on to it and move it for you, and all I'm going to do is bring your arm up and overhead as far as we can. If you experience any discomfort or you need me to stop because it is really painful, please let me know right away so that I can back off. But the more you relax, the easier this goes, which I know can be hard sometimes. Take some deep breaths and just keep me posted if you need me to go slower or back off, okay? All right, so when I'm moving the patient, 2 hands. I like to do 1 hand on the forearm and 1 under just proximal to the elbow, and then I'm just going to slowly move him up, watching his face, watching for any signs of discomfort. Don't let the arm get too lateral, right? Because then we're getting into more of an abducted position. So you want to try and keep the elbow close to him, and then all the way overhead until we see any signs of distress, compensation, or anything else that would indicate to us we need to stop. And actually, he's doing pretty good. Another thing I'm watching for is if his mid-back starts to arch off away from the table, which can be very common if the scapula is tipping and it's getting into the spine. Still doing okay, RJ? No pain? Okay. And I'm starting to get a little bit of a spring there, so I'm thinking he's probably got some muscle tightness. So now that he's here and he's, fairly supported on the table because he has good motion, now I can let go. Let's say we had to stop right here, and that's as far as it would go. Do you think the patient's gonna like that? No. So what I would do in that case is I would shimmy my top hand down. I maybe would let the elbow bend a little bit, and now I can relax my elbow onto the table. RJ, do you feel pretty supported here? Do you feel like I'm gonna drop you? Yeah. So I'm gonna adjust my hand position. I'm gonna make sure that I'm secure, because if I'm trying to hold him up and I'm shaking, that he's gonna feel that, right? And that's not gonna be comfortable. So I need to make sure that when I let go to grab the goni, he's supported, I'm supported, I'm not having to work hard to hold him up. He doesn't feel like there's any risk of me letting go or his arm dropping. Now I can palpate. All right, so the greater trochanter just spun in place, or greater tubercle just spun in place. You're gonna do that, I'm gonna do that, it's gonna happen. We're all the way up, there we go, sorry, I rotated you a little bit. There's my lateral epicondyle of the humerus, and then I'm gonna follow the body. Again, making sure that overall his spine is pretty straight on the table. I can't get a hand under there, because if he's arching, then I need to accommodate for that with my goniometer, right? But his spine feels pretty flat on the table. So now I can one-handedly follow those two landmarks, and I'll go ahead and let you come all the way back down, since I know you have good range of motion here. And if that were his full range of motion, that would be about 160. Fair?
Yeah.
Yeah, not too bad. And then, goniometer down, 2 hands on the patient. I'm gonna lower your arm down. Always let them know what you're gonna do before you do it, and make sure that for any passive motion measurement, 2 hands on the patient, they're comfortable and they feel supported. Okay? So that's flexion. I'll do extension in a minute just because it's in a different position. For abduction, new plane, right? Different cardinal plane, so we're gonna be up over the patient on this one. Or we're not. So, new fulcrum, now we're over the acromion. So again, you can find the acromion pretty easy laterally, but then you gotta move along the front of the acromion, right? So anterior part of the AC joint is right here. So again, easy to find the acromion laterally, just follow it forward until you feel you feel the joint. If you go more, you're gonna be on the clavicle, so come right back over the most anterior part of the acromion, okay? So that's gonna be our fulcrum. Our stationary arm is going to stay parallel to his sternum, and our moving arm is gonna follow the humerus. So for this one, again, cradle like a baby. You might even need to kind of pin the forearm against your body and then have 2 hands on the humerus, especially if you have a patient who's a lot bigger than you or their arm is heavy for you in terms of lifting. So now I've got some options. Now he's fully supported. If I need to go really slow, I can keep 2 hands on. If I see him kind of lifting up, I can tack down here to make sure that we're really getting good glenohumeral joint motion. And not getting like any sort of compensatory shrugging up here. So depending on what my patient does, what I see, I've got really good control here if I need it. Now RJ should not need quite that much support, but I'm still gonna keep 2 hands on him as I lift his arm out to the side, trying to stay down low to the table, not coming up this way. So as I lift up, I'm staying pretty low to the table, trying to keep his arm kind of parallel with his ear. If you imagine, remember the plumb line, the external auditory meatus and the acromion should be fairly level with each other in the plumb line. So that's kind of my guide, is making sure his arm is going up toward his ear. And then now here, if I'm running out of room, I can always ask RJ, can you turn your head away from me? And then bring your chin down towards that side a little bit. There we go. And now I've got more room, and I can abduct him even more. All right, so now let's say that's end range. So now I'm gonna let go with one hand. So I did adjust my hand a little bit up here, or if he's comfortable, I could even let that part rest on the pillow a little bit. And then coming back, his AC should still be in about the same spot. Shouldn't have moved too much. His medial humeral condyle is right here, so it's pointing straight up towards the sky. And then I need to get up and over him just for a second to make sure that my stationary arm is still parallel to his sternum, and that is 173 degrees. Does that make sense? And then 2 hands on him and let him know that I'm gonna bring his arm down. All right, so thought exercise. Did RJ have full range of motion actively? Did he have full range of motion passively? Pre-
No, but it was
pretty
close enough.
close. Yeah, it was a whole lot better. So if somebody has no, and he didn't say anything was painful. So if somebody has nearly full or full passive range of motion, but not full active range of motion, what does that mean?
Maybe it's a strength issue.
Could be a strength issue, absolutely. What else could it be?
Muscle tightness.
Could be some tightness. Yeah. And what parts of the body are we thinking about? What part of the shoulder? Is the shoulder just one part? No, the whole shoulder girdle could be at work here. So yeah, tight muscles. Maybe the muscles that depress and downwardly rotate the scapula are tight and are not allowing for the scapula to upwardly rotate correctly. So we're looking at, all right, pec minor. What's going on there? Are you a tight one? Oh yeah, he's a tight one. Maybe we need to do some release techniques there. Maybe some of the muscles that upwardly rotate the scapula or elevate the clavicle are not strong. All right, so we need to do some exercises there to get those muscles stronger. It's not always just the glenohumeral muscles.